Hi, we will discuss in this video interventional neuroradiology and anesthesia concerns and patient preparation for this procedure. It is a very interesting subject from neuroanesthesia, as interventional neuroradiology is a discipline that uses endovascular procedures to treat vascular conditions of the central nervous system. Other names of the field are neurointerventional surgery, surgical neuroangiography, and endovascular neurosurgery, which is very popular last one. On the right side, we have an image from X-ray with contrast, of course. Here, doctor detected some thrombi, and this patient will follow at the same day or on the next day after angiographic diagnostic angiography will follow thrombectomy. The access usually is from the hand or from the radial artery or from the femoral artery. Femoral artery is preferable because of the large size, and of course with catheter or guide we are going to the aorta back up and coming to the 5 arteries that are going out of the aorta. One of the interested of us represent a common carotid artery, which divides in internal and external. We are going through the internal, and we are in the circle of Willis called in the brain, and can have access by introducing contrast and going right to the side we need to the brain. So interventional neuroradiology is firmly established in the management of the cerebrovascular disease, and there is evidence that aneurysm coiling has advantage over surgical clipping and of the intracranial aneurysm. So think once again, access through the peripheral artery like femoral artery, and do not making any incisions of the scalp. Also, the perioperative and anesthetic management strategies to optimize conditions for therapeutic interventions, to prevent complications and to minimize the effects if they occur. We assume that the primary image technology is catheter angiography, and also magnetic resonance imaging may one day augment this practice. So planning of the anesthetic and perioperative management is predicated on an understanding of the goals of the therapeutic intervention and anticipation of potential problems. The anesthetic concerns of particular importance for interventional neuroradiology procedures are maintaining the patient immobility during the procedure, to facilitate imaging and to prevent intervention-related complications. Maintaining patient's immobility, patient often is get up for general anesthesia with intubation and muscle relaxation. Second one is either enabling rapid recovery from anesthesia to facilitate neurologic examination and monitoring, or providing for intermittent evaluation of neurological function during the procedure. Third one is managing anticoagulation, treating and managing sudden unexpected procedure-specific complications during the procedure, such as hemorrhage or vascular occlusions, which may involve manipulation with systemic blood pressure. Also, if there is detection of the bleeding, we can give some procoagulants, or if there is a thrombus risk formation, we can give heparin dosage like 70 units per kilogram. Guiding the medical management of critical care patients during transport to and from radiology suites, and recognizes self-protection, issue related to radiology or to radiation safety. Preoperative patient preparation and planning. Patient for neurointerventional radiology procedures ranges from healthy outpatients coming for diagnostic only neurointerventional radiology procedures to the critically ill, unresponsive patient in coma from the intensive care unit with devastating intracranial bleeds. Procedures may be elective or emergent, such as treatment of acute ischemic stroke. Thus, preoperative planning may vary significantly from patient to patient. Baseline blood pressure and cardiovascular reserves should be assumed and assessed carefully. This almost axiomatic statement is particularly important for several reasons, as blood pressure manipulation is commonly required and treatment-related perturbation should be anticipated. We can produce optimal blood pressure. We can increase blood pressure for increase in vascular flow and perfusion, or by other side, decrease blood pressure if this one is too high. Calcium channel blockers. Preoperative administration of calcium channel blockers for prophylaxis for cerebral ischemia may be used and can affect hemodynamic management. In addition to these agents, or transdermal nitroglycerin are sometimes used to lower the chance of catheter-induced vasospasm. Radiologic contrast is well known to cause allergic reaction. Allergy, remember, there seems to be no difference between the older and newer agents in their propensity to cause anaphylactoid reactions. However, newer agents provide a much lower osmolar load and therefore preserve intravascular volume in the event of an allergic crisis. The newer agents are also less neurotoxic than the older, high osmolar contrast agents. The patient's previous experience with radiologic imaging that may have included administration of contrast agents should be inquired about, as intraprocedural systemic heparinization is commonly used in interventional neuroradiology, even for diagnostic angiography. Protamine sulfate is also often used to reverse the anticoagulant effect of heparin. Protamine is also known as to cause allergic reactions, so be careful about these possible allergic reactions. In the history, items of interest include prior anticoagulation, coagulation disorders, protamine allergy, recent steroid use, and contrast agent reactions, including general atopy or iodine shellfish allergies. Patients who give a history of significant contrast agent reactions can be treated with steroids, antihistamines, and H2 blockators prior to procedure. The treatment for severe allergic response is reviewed in general textbooks and prominently features with the use of adrenergic agonists such as epinephrine. If you have access, you give directly intravenously, of course. And the patient renal function should be evaluated before the procedure due to nephrotoxicity of the contrast agent, and patient coming from intensive care unit may be intubated, mechanically ventilated, and have intra-arterial catheters and or the extravascular devices in place. And the last one is fundamental knowledge of radiation safety is essential for all member staff in the interventional neuroradiology suite, as well as critical part of preoperative planning. It is reasonable to assume that X-ray machine is always on, so they are working. There are three sources of radiation in the interventional neuroradiology suite, like direct radiation, leakage, and reflected from patients. So direct radiation are from the X-ray tube leakage through the collimator's protection, shielding, and scatter radiation reflected from the patient and the area surrounded the body part of the image of the body part which will be imaged. The amount of exposure decreases proportionally to the inverse of the square of the distance from the source of radiation. Inverse square law. Digital subtraction angiography delivers considerably more radiation than fluoroscopy, so digital delivers more radiation. Optimal protection involves the use of lead aprons, steroid shells, eye protection, and radiation exposure badges. The lead aprons should be periodically evaluated for any cracks in the lead lining that may allow accidental radiation exposure. Movable lead glass screens may provide additional protection for the anesthesia team. Clear communication between the interventional neuroradiology and anesthesia team is also crucial for limiting radiation exposure. With proper precautions, the anesthesia team should be exposed to far less than the annual recommended limit for healthcare workers. In this way, doctors should be at some distance from the patient, and we can insert some additional conductor for intravenous access and administering drugs that we need, and anesthetic drugs, of course. One time, again, reviewing as interventional neuroradiology is something new and very good for patients, as we are accessing through the vessel and not opening the scalp. It have many concerns for optimal anesthesia during this procedure. Patients should be prepared, especially with some vasodilators like calcium channel blockers, and doing some heparinization during the procedure, and of course managing the optimal blood pressure for brain to be supplied normally with blood, especially zone which is affected, and coming back from the collateral blood supply of the circle of Wills. We should know about our patient history of allergy and give some premedication like antihistamines, steroids, and in cases of allergic reaction right on the surgical room, we give even epinephrine, which is drug of choice. And of course, radiology safety. We should know sources of the radiation. We can have a special equipment which protect us, and distance from the radiation source. Thank you for watching and have a nice time.